Welcome back everyone. This video is going to cover bacterial endocarditis, which is caused by infection of the endocardial surfaces that can affect multiple valves. And the most common cause of bacterial endocarditis is Staphylococcus aureus, which is commonly seen in IV drug users. So what happens is that Staphylococcus is present on the surface of the skin, and once IV drug users are injecting drugs, it will force the Staphylococcus into their veins, and in the first place it will go to would be the right side of the heart. So it will cause tricuspid damage, and thus these patients present with tricuspid regurgitation as well as fever. And if you listen to their heart, what you will hear is a heart murmur in the left fourth intercostal space that is exacerbated by inspiration. In addition, due to immune-mediated vasculitis, deposition of immune complexes, as well as the presence of bacterial microemboli, these patients present with cutaneous lesions such as splinter hemorrhage that is seen under the nail bed, Roth spot, which is shown here. So there's a hemorrhage with a cotton wool spot in their center, as well as Osler nodes, which are tender lesions that are on the fingers and toes. And then there is also something called Janeway lesion, which is similar to Osler nodes, except that it's being present on the palm and the soles, and it's non-tender. So Osler nodes, which are on fingers and toes, are tender, while the Janeway lesions, which are on the palms and soles, are non-tender. Now there are different forms of endocarditis, and I've just discussed the acute bacterial endocarditis with you, which is caused by Staphylococcus aureus, which is an organism that is highly virulent, and it affects the previously normal valves, and it's usually seen in IV drug users, as a consequence of which it will cause tricuspid valve damage. The next form of endocarditis is called subacute bacterial endocarditis, which is caused by low virulence organisms such as Streptococcus sanguis that belongs to the Streptococcus viridans group. And in these patients, since there is already fibrin deposition on the damaged valves, the bacteria will form dextran or glycocalyx from the sugar and would be able to now bind the fibrin. So again, with subacute bacterial endocarditis, there has to be a previously damaged valves to have fibrin for the bacteria to be able to bind to it. And then the final form of endocarditis is non-bacterial verrucous endocarditis, which is seen in patients with SLE, and the other name for it is Liebman-Sachs endocarditis. And one high-yield point is that there would be vegetations on both sides of the valve leaflets. Now here we have procedures that increase the risk of endocarditis, and these include cystoscopy, which increases the risk of endocarditis by enterococci. Then we have skin injury or IV drug use, which we just discussed, causing acute bacterial endocarditis by Staphylococcus aureus. If there is a sign of endocarditis but the blood culture is negative, then you should suspect infection with Hasek species, and these include Haemophilus, Actinobacillus, Cardiobacterium, Acanella, and Kingella. Dental extraction increases the risk of infection by Streptococcus viridans. Colon cancer or colonoscopy increase the risk of endocarditis by Streptococcus bovis, and the other name for it is Galolyticus. And then finally, patients with prosthetic heart valves can develop endocarditis by Staphylococcus epidermis. Now, if a patient has sign of endocarditis, best initial test to order is the blood culture. And then later on, you can order transesophageal echo. But if a patient already has a prosthetic heart valve, then you should directly jump to the transesophageal echo. The treatment for patients with endocarditis is IV, so not oral, IV vancomycin and gentamicin. And if you recall, vancomycin can cause flushing, so if once you're giving the IV, and if these patients develop flushing, or also called red man syndrome, all you have to do is decrease the infusion rate. You don't need to provide with any additional medications like diphenhydramine. And then patients that have prosthetic heart valves, you should also provide rifampin to enhance penetration of the drugs into the center of the endocarditis. Now, as for dental procedures, if a patient has a prosthetic heart valve, heart transplant, a congenital uncorrected heart defect, or previous episode of endocarditis, then you should provide prophylaxis treatment with amoxicillin 1 hour prior to the procedure. So not during the procedure, not after the procedure, 1 hour prior to the procedure. And if they ask you what kind of prophylaxis you need to provide in patients with mitral valve prolapse, as you notice, MVP is not listed among here. So you don't need any prophylaxis for patients with mitral valve prolapse. And then one other important point I would like to mention here is that glomerulonephritis is the most common cause of death in patients with endocarditis. So since there are so many antibody and immune complexes that will clog up the kidney, these patients will die usually of glomerulonephritis. Now the memory aid that I have for endocarditis is called blend vegetations. So endocarditis is associated with vegetations, and the first test to order is the blood culture. And then the treatment is IV vancomycin and IV gentamicin. So blend vegetations, N goes for endocarditis, BL goes for blood culture, the first test to order, and then vegetation, V and G goes for vancomycin and gentamicin via IV route to help treat these patients. And that concludes our discussion.